Well, good morning, everybody. It looks like we're at 11:45 or maybe a minute later, so I think we'll go ahead and get this session started. Welcome. I hope you're having a good weekend so far. I'm coming to you live from Chapel Hill, so I'm about 10, 11 miles down the road from my Duke counterparts who are over in Durham. So again, welcome. This morning, if it's morning where you are still, here in the United States, I guess it should be. Presenter view turned on. I haven't. I'm seeing it. I'm not. I guess I'm seeing in my questions and answers that it's not turned on. I'm not sure how to do that. I'm good. Okay. You got it. All right. We see you. We hear you. Okay. Good enough. Maybe. I guess maybe good, maybe not. Anyway, what I'm going to talk about today is the oral manifestations and management for caries. Yeah, these platforms are a little interesting doing these things. I've done quite a few of them, and this one's pretty cool because it looks like a movie theater, and they've got a lounge. I hope you were all in the lounge or in the exhibit hall or whatever. So it's been pretty neat, and appreciate Softbuds putting this on, and I appreciate the participants coming on and listening. I presented some of this material in a webinar a month ago, back in April or something, a couple of months now, but some of it's a little different. Some of it's in response to questions that I had at that session that I wasn't able to answer. So we'll just move on. So one thing you need to keep in mind is you may have hypophosphatasia, or you may have a family member with hypophosphatasia, and they will have issues related to hypophosphatasia, but they got all the other issues related to just oral health in general anyway. And you may have other things that are hereditary in addition to hypophosphatasia. So I'm going to talk about some of those health issues, some of them that are HPP specific, some of them just general oral health issues that we all face and deal with, and how that may differ with hypophosphatasia, and how you may want to manage it a little bit different than if you didn't have hypophosphatasia. So really looking at a lifetime of oral health, and with hypophosphatasia, that's truer than most, because most people, I'd say a majority, if you look at the studies that are out there, have dental issues of one kind or another. In the spectrum, as you heard about from several of the speakers already, talk about the spectrum of hypophosphatasia and the continuum, and dental is frequently a component of that. They address the odontohypophosphatasia as just being part of that spectrum and probably not a separate entity when you really look deeply at what the manifestations are, what kind of clinical characteristics you might have. They might be subtle as a child, but continue to play out through your lifetime. So early on, diagnosis, do you have hypophosphatasia or not? And what are you going to do about it? All the preventive things that we do. As you move through childhood to adolescence, you continue to monitor how they grow, the growth and development, how the teeth are coming in and changing out, starting to think about periodontal health, which you may have. You have untreated hypophosphatasia, you may have lost teeth early on as an early manifestation of hypophosphatasia. And then into adulthood, you continue that, hopefully continue disease prevention, both caries and periodontal disease, which are the two big hits for oral health. Not the only ones for sure, but those are the two biggest. And then tooth restoration, tooth replacement if you have lost teeth. And I'll talk about implants and some of the issues related to that, what we know and what we don't know. So early on, I've got this picture. Here's my Duke, one of my patients who came in all dressed up for Duke. And if I'm sure most people know, there's big rivalry in basketball predominantly here in North Carolina. And but I thought it was great. Kid came in all dressed up like this, and I love the picture. Anyway, again, diagnosis, genetic counseling, you've heard about these things, talking about how do you prevent preventable diseases. In this case, for us, it's predominantly talking about dental caries and how do you stop that. Unfortunately, there's still many, many children who have rampant disease. I was in clinic yesterday, Tuesday or Thursday, I guess, 2 days ago now, and saw 3 2-year-olds with abscess teeth. And that's a preventable thing related to diet and to preventive care that you can do. So that's what we're trying to do in the preschool kids. So doing things like anticipatory guidance, a fancy way of providing information as to how to prevent disease and do that. Do they have enamel defects? That's more prevalent if you have hypophosphatasia. What are the dietary issues? And a lot of people don't realize, everybody knows sugar is bad for your teeth. But a lot of them folks will say, well, they get juice, but I dilute it. Well, diluted juice, even if you diluted it at 75%, there's plenty of sugar in there because the bacteria are really small. And it's the frequency with which you do that. So sitting down and gulping a glass of juice or a soft drink is not as bad as walking around sipping on it all the time. Sippy cups, straws, things that are convenient because kids slop stuff all over the place. Some adults do too. But anyway, it's the frequency with which you have those issues. Salivary flow, which is an issue for more so for adults than it is for kids. Hypophosphatasia doesn't affect salivary flow as far as anybody's ever reported, and I don't know why it would, but it's not reported to do so. But other conditions do, certain medications do. And then fluoride exposure. Water fluoridation, if you have it. Fluoride supplements, not used as much anymore, but still out there if you needed them. And then all the topical things that you can put on. Toothpaste, varnishes, fluoride rinses. Right now in COVID, when you may have not been to the dentist as frequently or at all since all this began, about 75% of dental offices are opening back up right now, but in some places they may, I don't know what will happen, but they may well shut back down because of the extensive amount of disease that's out there in the population. So optimizing your prevention right now is really a good thing to do. So to keep your dentition intact while you may not be getting as regular dental visits, or your child may not. So something to think about. Fluorides can help. And I'll talk a little more about what some of those options might be. But so tooth decay is one of the big players. As you become an adult, periodontal disease becomes more of an issue, not as big an issue in kids. But tooth decay is just the demineralization of teeth caused by the bacteria that metabolize carbohydrates. And it's just a dissolution, literally an acid dissolution. And this is just showing the white spots that start to form as first, and then as you lose more mineral, they cavitate, and then they get into bigger cavities. And eventually you can have abscessed teeth. One of the questions I had from the webinar recently was they had orthodontics and they had these white rings around where the brackets had been. That's where the teeth weren't cleaned as well as optimally around the bracket, looked very much like this. And they got decalcification, and that's the first part of the cavity formation around those brackets. It's a common occurrence with orthodontics, which is one of the reasons why we recommend using fluoride rinse and really being careful about your hygiene and diet when you have braces on, because it makes this process more likely to happen. So that's what we're trying to prevent. Fluorides are very helpful in this. Remain controversial as far as fluoridated community water fluoridation, but the evidence, they just celebrated 75 years of community water fluoridation in the United States. Millions and millions of people, about 70% of the population, have access to that. It's inexpensive and it's highly effective. Population-wise, you get about 25% caries reduction, regardless of socioeconomic status and those things. So water fluoridation remains a real bonus for us. But there are other therapeutics out there as well. Toothpaste, so they're self-applied things professionally. Toothpaste is a big one. Most everybody brushes their teeth, and about 95% of people use the fluoridated toothpaste. You're not using fluoridated toothpaste, even for an infant, you're not getting much of a benefit. You're not getting any caries benefit from the toothpaste if you're using one of the ones that doesn't have fluoride in it. In fact, just brushing your teeth alone is not very effective for caries. Fluoride is, though. Toothpaste, again, kind of like water fluoridation, you get about a 25-30% caries reduction in the population if you do that. Mouth rinses, there's over-the-counters at different concentrations. We don't recommend those for little kids, but if you've got somebody over the age of 5 or 6 that's good at swishing and holding it in there for 30 seconds and then spitting it out, those can be helpful as well. Again, these are things you can be doing at home right now to help prevent yourself from having problems, you or your kid or whatever. We in the office can provide fluoride treatments that are much more concentrated than what you can buy in a toothpaste, like 20 times as much. So you don't do this every day. You get these like maybe twice a year or 4 times a year. The more you put it on, the studies have shown the better they work. If you only did it once a year, they don't work that well. A lot of adults don't get fluoride treatments, but they help as well in adults for root caries and coronal caries. So varnish is what we commonly use, where we paint it on like this, but there are other things. Silver diamine fluoride is new on the market since 2015, and I'll talk a little bit more about that as we roll through this. So using the appropriate amount, if you look at, So I'll go back. So this picture's how you see all the ads for toothpaste. You don't need that much toothpaste. Even an adult only really needs a pea-sized amount, but especially for kids, we recommend not using excessive amounts, especially under the age of 3 or 4, because they're going to eat it. It tastes good. So we recommend until at least the age of 3, using just a tiny smear amount, and after that, or around age 4, 3 to 4, switching to a little tiny pea-sized amount. And sometimes we'll say it's a grain of rice size or a little pea size. So that is especially in kids. Once you're an adult, if you want to glob it on there and do it, that's fine. But kids, you really don't want them eating all this stuff because it will affect the formation of the permanent teeth, and it'll cause them to have white spots. And if they ate too much of it and had water fluoridation and eating a lot of toothpaste and other things, it'll actually cause the enamel to could potentially discolor and even be not as well mineralized as it should be. So this is cute, but not good. So I actually just got a picture. I didn't put it in here of one of my nieces where she had gotten into the bathroom, and she's about the same age. She's like 3-ish, and had been in there eating the toothpaste, and you could see the stripes of the toothpaste across her face. At first I thought it was cake icing, but she'd gotten into the toothpaste and was in there eating it all. And so use the right amount. Fluoride varnish, again, this is something that we do in the dental office, so it's very effective. We paint a very thin coat over the teeth, and you're using like a half a millimeter, not millimeter, milliliter, just a tiny amount that covers it. And again, this has been shown to help prevent about 30% of cavities in a population. So you just clean them and dry them and paint it on there. I have heard about some folks talking about handing this out in some school-based Caries initiatives to families to put it on at home for kids that are not able to get out, haven't been to school, and have been sequestered now for 5 months and maybe longer. I don't know what's going to happen with schools. I'm involved in one of these school-based initiatives, and we really don't know what's going to happen yet as far as going back to school, despite all the desire to have everybody in school. So anyway, fluoride varnish is very helpful as well in preventing cavities. So that's professional and more concentrated. These silver salts are on the market. Silver nitrate's been around forever. Silver diamine fluoride is the most concentrated fluoride that we have that you can paint on teeth, and it's used predominantly to stop a cavity. So if you have a cavity and it started, you can put this on there and it'll stop it. It can be useful in adults. This could be very useful, for example, for people who are right now in nursing homes or other facilities, home type facilities, and they're not going to be able to have access, and they're very restricted as to who can come in and go out of those facilities right now because of the COVID issues. So if they're having or developing cavities, if people could get in there, a hygienist or a dentist or somebody is partaking care of those people, this would be something that could be very useful in helping manage disease, especially right now when you don't want to be carting those people out to dental office or having a whole bunch of people go in to provide dental care and bring in a bunch of dental equipment that generates aerosol and those kind of issues. So highly effective for stopping tooth decay. Good for kids and adults. So this is a kid that came in. They wanted us to consider taking this kid to the operating room or sedating him because of these cavities, which are not huge. But one thing is that this stuff will turn these spots black. So as it stops the decay, it turns black, which is part of the silver, and it gets hard. So if it works, and it works about 70% of the time with one application, 60, 70, and it works about 90% of the time with 2 applications. So this little girl, they decided to do this instead of taking her to the operating room, little cavities on the backs of these teeth. And she still didn't like this. I mean, 2 or 3-year-olds are not crazy about you doing anything to them. So, but it's not painful. It's just, she just had to sit there for a minute and take it like a kid. We put the fluoride varnish on top of these things afterwards to treat all the areas, not just the cavity areas. So we put the silver diamine fluoride in the little cavity spots, then we paint varnish over the entire mouth to help prevent cavities. Yes? Okay. So here she is. She's happy. She's got her tiara ready to roll. Here she comes back. We see everybody back in a month, 6 weeks to see if it worked and do we need to reapply. And more importantly, talk to them about how's it going with the diet. You know, you'll be able to brush at least once a day now, using a fluoride toothpaste and all the other things that's going to prevent this, because this may stop this cavity, but it's not going to stop a new one from forming over here, or this even reactivating. So it turns dark. This is good. So black is beautiful with tooth decay. And some parents won't accept this, or some patients may not want to have this just because it's anesthetic. Now, you can go back in and fix this and put some filling over top of it at this point, but the little girl didn't care. But so that's an option for treating now. Here they are on the back side. So any place there was a cavity and we put it on, it turned black, but you can also see that the rest of the teeth and the rest of the areas that aren't cavity, they don't have cavities in them, they don't turn black. So it's selective as to where it has an issue. Pits and fissures tend to disproportionately have more tooth decay than any other surface in the teeth. The permanent first molars, when you're 6 years old and those things come in, those teeth frequently decay within months of coming in the mouth. So sealants can be very helpful in managing that. So it's not uncommon to see fillings in these teeth, or here's all these are baby teeth, and got all these little nooks and crannies with spots in them. So sealants is a plastic or a material that flows into these nooks and crannies and mechanically obliterates them. So you've got all these little holes and nooks and crannies, this electron micrograph of a molar. And the plastic or the material, there's some are plastic and some are other materials, will fill these in and seal them off, literally the seal, and stop the ingress of bacteria and food into these stagnation sites so they don't become decayed. So you're not going to clean these out. You know, people come in and say, well, they brush. I don't understand why they're getting cavities. Well, this is a toothbrush bristle off of a toothbrush. And you can see that it's not, this is a shallow one. This is not an uncommon deal. And the cavities, this little dark area is sort of the beginning of demineralization, loss of mineral. You're not going to have an effect on that other than maybe getting some fluoride around in here, but mechanically you're not really doing anything, and certainly not doing anything to these kind of fissures, which are common. So sealants is the way to go. So, yep. He could have, Austin Powers needed sealants or something. So this is an unsealed, and this dark in here is the depth of the fissure and some demineralization starting around it. And this is just a fluorescent picture showing a plastic resin that just occludes this area off. So that's how they work. So here's a white one, and they come in different colors. Some are clear, some are white. This is unsealed, this is sealed. So it fills in these little developmental defects that are typical of teeth forming. So about 75% of, if you took a population and you got 100 kids, you're going to stop about 75% of the decay in those teeth if you do that. So again, if you're combining, usually for oral health and caries management, it's a combination of these things that you're trying to do. You've got to use fluorides, which are not as effective on pits and fissures, and then you use that, the sealants to address that issue, and so it's multifaceted. Diet discussion. Some people have been concerned about the chemicals in these things. The resin ones have, they used to have BPA, bisphenol A, but you get much more exposure to that just from all these other things, and most of the sealants don't have that in there anymore. And there's others that never did have any because they're not using the resins, they're using another kind of material. So they're safe regardless of which one you pick and choose. So teeth from a genetics point of view, and hypophosphatasia being one of these things, alkaline phosphatase is important in tooth formation. There's thousands of genes. So alkaline phosphatase is important in mineralized tissues, and tooth is the cementum, the dentin, and the enamel all use alkaline phosphatase and are affected by alkaline phosphatase changes, can be. So that's what you're dealing with hypophosphatasia. So it's critical in these issues. You can have enamel defects. Not everybody has enamel defects. You can have dentin defects, which you normally don't see, but the mineral of dentin is frequently less, just like it would be in bone. And then the cementum is the outer lining of the tooth that helps anchor it, the fibers and the collagen fibers that cross over to the bone and help hold the tooth in. That's the attachment. That cementum layer is deficient frequently in alkaline because of the alkaline phosphatase deficiency, inactivity, and the mutation in the tissue non-specific ALP gene. So that's the part of the dental. So premature tooth loss is common. And if you look at the different groups, this was alluded to by Dr. Crisniano this morning about the odontal hypophosphatasia, but even in the adult group, frequently they will have recalled, fairly high percentage they will have recalled that they had a missing tooth. So again, it's really the spectrum, and it's not the age. It used to be the age at which you were diagnosed, or what are the clinical phenotypes, and we'll name it after that. But it's really this sort of continuum of the spectrum of what happens to you as an individual if you don't have normal functioning alkaline phosphatase, not enough or not normal functioning, and what does that do to your dental development. Tooth loss is a common one. And so early tooth loss beginning at a year and a half or so is one of the telltale signs of hypophosphatasia. Not the only thing that causes that, but you frequently see, like this little fellow's got gums look healthy, teeth look clean, and his teeth started falling out about 18 months or so. So not an uncommon finding. And again, the reason for the tooth loss is not because of periodontal disease at this age. For this part of it, you can certainly have that as an issue later on, but this is a normal cementum layer. This is the dentin with these are actually little tubules that run in towards the pulp. And in the hypophosphatasia teeth, in this particular section, there's almost none. There's a little bit right here, but none here. And this is abnormal mineralization in the dentin. So they frequently will have issues with that as well. Doesn't really, you can't see it unless you're looking at it with a microscope or something, but we don't know whether or not that causes issues or not. Certainly the cementum and enamel defects can. The dentin could make a tooth more likely to fracture, and that's not an uncommon occurrence in adults, and it's probably more common in people with hypophosphatasia, although there have been no studies on that I'm aware of. So yeah, this is the cementum and these little fibers right here, periodontal ligament. It's like it is a ligament, and those fibers run in and attach into the cementum, and then they run over to the other side where the bone would be over here, and that's the sling that holds your tooth in. And it also is the sling that provides some bounce, some resilience, so that teeth take a huge amount of force on them when you're chewing. And so this is part of the shock absorber that helps teeth to not break and not fracture, because there's a little bit of oomph and a little bit of give right here in the system to allow them to take that kind of force. And even though they're brittle, enamel especially, the outer hard surface of enamel is almost like a ceramic. It's almost pure mineral. It's hardest mineralized tissue in the body to not break as often as it might. You can still break it, but not as commonly. So tooth loss occurs in all of the different groups, regardless of the classification. It tends to be earlier. This is, Michael, I'm citing Michael Wright here and some of his excellent reviews on this. Tends to be earlier and more severe forms. This is not an uncommon occurrence. And the other things you'll see here is the bite, and I'll talk a little more about that. But there's a constriction in the maxillary, the top jaw, maxillary arch. Lost teeth, lost all these incisors. You can see around here how the gums are receding down. If you were an adult and you had this, they might consider doing a graft on this. Periodontist might. And a child like this, it is what it is. And this tooth is probably headed for premature exfoliation as well. But so this is a good example of an open bite. Kids that suck their thumbs will frequently have this kind of and kids you may have hypophosphatasia and suck your thumb. That's likely to make all this worse. So that would be something you'd want a kid to stop sucking their thumb maybe a little earlier than later. Maybe get them to stop by 3 if they start that, so that they are less likely to have this constriction of the top jaw and this anterior open bite. So that won't help things at all. So number of teeth loss goes up as the disease goes up. Here's another little fellow, same kind of pattern. The incisors, sometimes it stops at this. It doesn't go on. I mean, it may be 2, it may be 4, and then the back teeth not so much affected. They're forming a little bit later. They have more root structure. These are the smallest teeth down here in the mouth. They're teeny tiny. So they seem to be the ones that go first. They're forming earliest, and they normally fall out earliest as well, but they usually fall out. These usually are falling out around age 5, 6, not age 1.5. So, and they usually fall out with with the root being dissolved away. Because the way this normally works is this is an x-ray of a kid with hypophosphatasia. There's almost no bone left around this tooth, which is getting loose and getting ready to fall out. Again, the reason is that if you don't have the cementum, you don't have the attachment to the bone. So as far as the bone goes, there's not really a tooth hanging there. And you don't have that sling to hold it in. So the bone is just sort of dissolving away around that. And the bone itself is not as well mineralized either. So all of that's counting against you. Normally, as a permanent tooth develops, it would move upwards, and this root would slowly dissolve away. It's programmed to do that, and then it would fall out. In this case, it's just falling out, and these teeth are not anywhere close to coming in. So they're going to have a toothless front tooth smile for a little bit. Again, this is just electron micrograph showing the nice fibers and this attachment of cementum that would run over into the bone out here on the other side. And this is this hypomineralized dentin in there where you can see it looks quite porous here. This is normal. It's very dense. It's got collagen and mineral. It's about 65% mineral. And here that mineral is reduced, and you can actually see these voids where it just didn't work. So the alkaline phosphatase would be helping to manage the phosphates in there, the pyrophosphates that would inhibit mineralization and liberating phosphate that's important for developing the mineral of the hydroxyapatite crystals. That's what it's called. The mineral is called hydroxyapatite. So it's a calcium phosphate crystal. This is telltale of hypophosphatasia, a couple of teeth with full roots on them, and normally the tissues, like I said, they look healthy. They don't look like they might if you have leukemia or some other sort of systemic disease that would cause all kinds of problems. You may have a little bit of resorption, but normally this root would be all the way up here where the crown would start. The enamel comes down to right about here, and then the rest of this is root and would normally be cementum. So that is the underlying problem for tooth loss. You can have enamel defects. Not well studied as far as genotype, phenotype, but my guess is that if you look at the more severe cases, they're probably more likely to have this. And it happens in a fairly prevalent, there's several studies that show that it's fairly prevalent. It's not everybody by any means, but 15-20% of people will have this. A lot of people have enamel defects anyway, but it's a higher prevalence, and this is an actual deficiency where there's just not enough mineral formed in these teeth. Not the thickness of enamel is not formed properly. So you get these pits and grooves. It can be generalized thin all over the teeth. So can have a couple of different manifestations. This is an example of a little kid. This was a paper out of Japan, 2016, and showing the pretty significant enamel defects. And not all teeth are affected equally. So these teeth are beginning to mineralize and form in utero. These parts of these teeth are forming later on, and they seem to be more affected. So there may be a timing issue and a tooth issue. These are front teeth, back teeth, and they don't all mineralize the same. So, but that's all baby teeth with significant enamel problems. How do you deal with that? This is actually too much fluoride cause this kind of a defect, but you can bond these teeth, put crowns on them. In this case, this is just a transitional kind of thing so that they look nice for this kid who didn't like this appearance, and his classmates didn't like it either and would tease him about it. So easy to fix to be able to bond these things if they're willing to sit still in a chair and they're motivated to do it. So crowns, bonding, those kind of things are all ways to manage that. Cracks in teeth, that's part of that's as you grow older, you're more likely to get cracks in teeth. I don't think, with population living on average to be like 78 years, I'm not sure teeth were genetically engineered to last that long in general, although they do, and there's a great association between longevity and oral health. If you keep your teeth, you tend to live longer and better. But cracked teeth is not an uncommon thing. My guess is that because of the combination of enamel defects and decreased mineral of the dentin, people with hypophosphatasia are probably at greater risk for having fractured teeth. So if having treatment of all of the, if you're on replacement therapy for the alkaline phosphatase, extrinsic then we don't have any data yet as to how all of this may change the life course of the oral health. The evidence would suggest in the animal studies and preliminary stuff that it's going to help reduce some of these things that we're seeing. But we don't have those studies out yet to really know what the dental outcomes of that therapy would be. But on the studies, preliminary studies, it all looks good. Animal studies look good. Fracturing of teeth like this, I mean, I don't have hypophosphatasia. I fractured off a chunk of a tooth. This is not where the filling broke. This is where the tooth broke away from the filling. So that's not an uncommon thing, but again, no studies I'm aware of, but I think it's probably more common than hypophosphatasia just from what I've heard. Periodontal disease, I get questions about that a lot. So this is the only study I'm aware of where they actually looked at people with hypophosphatasia. And again, they only looked at a few of them, 7 males, and compared their oral bacteria to those of people without any disease. The middle white bar is controls, and then people with periodontal disease. They had periodontitis. Most of the bacteria that you would see in the periodontitis that are thought to be associated with the disease, the hypophosphatasia people did not have that. They did have a lot of streptococcus, which strep mutans has been associated with dental caries. So whether or not people with hypophosphatasia have more tooth decay than other people, there's no study that I'm aware of where anybody's actually looked at that and quantitated it effectively. So if you're gathering that I'm suggesting there's a lot of room for research on hypophosphatasia and oral manifestations, you are correct. There's a lot that could be done and learned. But anyway, the good news is that, yes, there are issues with the periodontium, but I think it's mostly, at least initially, it's the structure and the predisposition because of the cementum and the fiber attachment. But that predisposes you to having tooth loss that somewhat mimics periodontal disease, but it's not the inflammatory biofilm mediated necessarily, at least initially, that we see in periodontitis in the population. But if you get periodontitis on type of hypophosphatasia, you're probably going to progress more rapidly and be more severe. So tooth loss, again, what do you do about this? Well, you want to prevent as much as possible from getting periodontitis. So you don't want to have the biofilm. You don't want to have local irritants. This is the tartar calculus that forms, especially around the backs of your lower incisors because your salivary glands dump out right down here. And that's got mineral in it. And so that will precipitate on your teeth, and that will be an irritant to your gums. So again, right now, going to the dentist and getting your teeth cleaned is a good thing still to go ahead and do. Yeah, enzyme therapy, we don't know, again, whether or not this will help the HPP-associated attachment loss with teeth, but the evidence in the animal studies would suggest that it will. So one of I don't know how many of you folks have had like an ultrasonic cleaner. You go in and get your teeth cleaned. If you have this, they have these ultrasonic tips that blast water all over the place. It's super aerosol producing. So some people are a little reluctant right now because of the aerosol issues to pull that out. I know Thursday there was a teenager I would have liked to have pulled it out, but just because of the aerosol production, I did everything by hand. The little scrapey, pokey things that we use in dentistry to clean all this off because it's generating way less aerosol, which is putting me at greater risk because he's already got whatever he's got in his mouth, but the staff and then the aerosol that's in the room and how long it's going to float and all those issues. So things are a little different right now in the current environment. So this is what happens when you have the biofilm will sit on the teeth, or this tartar calculus is an irritant. The gums actually recede down and they're inflamed. The body is responding to this insult, and so it has inflammatory mediators in here that's trying to correct and fight this infection. And so that's what periodontal disease. Normally there's an attachment. This is the sling on the tooth, and then the gums, actually the tissue, the mucosa, your gums is actually attached right below the crown of the tooth where the enamel is. And if you have these environmental stressors or inflammatory mediators, then that epithelial attachment will go down, and then it becomes harder to clean, and that's periodontal disease at this point. And the bone will then start to dissolve away as well. So keeping your teeth clean, flossing. People asked about water pick. There's the new water pick toothbrush that's on the market. Water picks, and somebody had asked at the webinar about the intensity of pressure with that. So you don't want it to be too high because it will penetrate. It can actually break that attachment down if you had it too high. So you don't want it like a pressure washer or your side of your house. But higher pressure is probably going to clean a little better, but regardless of how much pressure it is, it will never remove all the bacteria and the biofilm on the tooth. It'll help get the big stuff out, but it's not as effective as like using a floss. And there's all kinds of other little gadgets and gizmos you can use to help clean, little brushes, proxy brushes, the Stimudent toothpick kind of things. All of these can be helpful aids to help get in between and get the tooth cleaned around so you don't end up with this going on. And once you do have this, then you really need professional help, a periodontist or a dentist to help get this cleaned out. And there are medications you can put in here to help manage this, rinses and other things. How about replacement of teeth? So there's fixed and removable prosthesis. Fixed would be like crowns, bridges, and removable would be like dentures, which may be to replace a couple of teeth or one tooth, or it could be replace all the teeth. This is somebody who's had their teeth capped over, probably had a root canal in them, and then they put these, and then they put a denture over top. It's called an overdenture. So that's one way to manage missing teeth. People have asked, well, will they stick onto the hypophosphatasia teeth? Well, this isn't stuck on, it's just overlaid. So whether you have hypophosphatasia or not, that's not an issue. Bonding types of things, the enamel typically in hypophosphatasia is going to be adequate to bond to. Sealants, bonding, aesthetics, resins, plastic, fillings, all of that should work for the most part, depending on the severity of the case. Full coverage crown usually is mechanically and then cemented on there. It's got mechanical retention by design, and then the cement's used to lute or stick the thing on there, going to help it stay in place. So all of those are options. There's not, again, a lot of literature on this. Implants is another thing that people have asked about. This is the only paper that I'm aware of that's ever been published on implants in hypophosphatasia patients, and there are only a couple of cases in here, or 2 cases. And they were stable. One of them had an implant fail, and it was in the upper jaw. Upper jaw implants fail more frequently than lower jaws. Now, in the paper that was alluded to this morning in one of the talks, Tom Weber was lead author where they did a survey at Duke on 125 adults. 16% of those patients reported that they had had implants placed. And there's probably people in the audience listening that have had implants placed. So again, a survey, a questionnaire to the people out there with hypophosphatasia who've had implants would actually be helpful in the literature to document how many have had issues with that, or how they've worked, have you had issues, where were they, that kind of thing would actually be a very useful study to have and inform clinicians who are wondering, is an implant a good idea in a hypophosphatasia patient? I think there's evidence to say, yeah, you probably want to proceed with a little bit of caution because the bone may be a little different. And again, are they on therapy or not therapy? Bisphosphonates came up this morning as a potential therapy that was not recommended for hypophosphatasia, but that is usually considered a contraindication to doing implants because of other issues with the way the bone physiology reacts to that therapeutic. So still stuff to do, but in this case, the implants looked, they were in there and they had fairly long-term follow-up and they worked well. And implant therapies have gotten a lot better now than they were even 10 years ago. And they continue to evolve as far as the shape, size, materials, and even the restorations and the way that they put them on top. They've got zirconia implants now. You know, there's all kinds of stuff out there. Not my area of expertise, but there's lots going on. Craniofacial features. Again, this open bite, missing teeth, cross bite, and the top teeth being inside the bottom teeth. Those are all features. No studies on this. This is just my personal things that I've seen and some in the literature that are reported in case reports where you see this kind of appearance. Head forms will vary, and if you have craniosynostosis, depending on which sutures might be fused prematurely, will help determine what kind of head shape that may lead to. That can have effects on the growth of the face as well. So those can be issues. So Craniosynostosis is variable, so is cranial morphology, head shape, just in general population is quite variable. But anterior open bite is something that seems to be more prevalent in this population and in people with HPP than in the general population. So this little kid's got a kind of a longer front to back sort of head form. Traditionally, we've used x-rays to look at these. Now, this is a case report of hypophosphatasia where they're using the CT scan kind of thing, give you 3D images, and you can see the open bite. And this is an adult dentition. It's only hitting on these back teeth. None of these front teeth actually touch. So no studies on it, just these case reports and my own personal observations in patients I've treated. So yeah, this is the skull, depending on what sutures might be affected. Mid-face growth is not uncommon. The bones in this part of the face are affected by many different conditions. So it's not altogether surprising that they may have issues with the way that the jaws come together. So normally, traditionally, if you go to an orthodontist, they're going to take x-rays like this. This is a little kid with the hypophosphatasia, and this is an adult. And in this case, the mid-face is not as well developed at this point, so he grew that way. So variable, but how about orthodontics? Can you do orthodontics? In most, I've known people that have had orthodontics with hypophosphatasia. Some of them said they really started having troubles after that. So I wouldn't say no, but I would say proceed with caution and understand that some of the issues that occur in people anyway, like roots potentially resorbing or teeth getting looser than they should. If I was the orthodontist, I would just proceed with caution and use light forces and go slow and steady, not try and bang through this or use real heavy. There are some heavy force types of orthodontics, like the headgear that this little girl's got on right here. And it doesn't say that you wouldn't do it, but if you did, I would certainly monitor very closely. I might take some x-rays more often, so just proceed with caution if you're doing that. Another thing to consider, I mentioned early on about getting cavities around these things. So everybody that I have in braces, I recommend they use a fluoride mouthwash and they be meticulous in keeping this area clean around these brackets, which can be tough. And then this is not good. If you start to see this kind of thing in any patient, but certainly in someone with decreased alkaline phosphatase activity, this would not be good. I'd be worried about periodontal progression in here. And I would watch that very carefully. And if that didn't resolve, I might consider just, all right, the risk is outweighing the benefit here. Because if you lose these teeth, you can put plastic ones in there however you want. Pretty easy to set up dentures with whatever, but you don't want to lose teeth in young patients because the teeth help drive bone growth. So if you lose teeth, that's not good for bone growth. Invisalign, that's being used more and more, and that may be another way to use lighter forces and slow moving, and it also alleviates some of the issue related to the decalcification around brackets and the caries issue. So that's another consideration, and that's being used more and more in dental offices these days. So this was the survey that they did, Dr. Kishnani and Tom Weber over at Duke, and I thought this was interesting. So this was where I got the 16% implants. And they also had 44% with root canals. And then I was trying to figure out in the United States, is that really high or not high? And those numbers were not that easy to find. There's not been a big, huge survey, but I went to the American Endodontic Association website. They said about 25% of adults in the United States have had a root canal. There's millions of these done a year, but that to me then would suggest that number is almost twice as high as the general population. Why that number is so high, it's probably a combination of things, but it could be cracked teeth, but that wasn't part of the survey, didn't get that granular, so I don't know the answer to that, but it does suggest dental issues, both of these numbers are high, so dental issues are part and parcel for hypophosphatasia, and they need further study to help really say how can we manage this. David Satcher's quote, "You don't have good health if you don't have good oral health." So true. So dental people are frequently frontline diagnosticians, although hypophosphatasia is picked up more often than it used to be from other groups. But the falling out of the teeth frequently can be a telltale sign and maybe the first thing. We've had several cases we've diagnosed that based on this, and they hadn't been diagnosed previously. So it's good for dentists to know about this. This was mentioned earlier about the clinicaltrials.gov being part of a registry and would allow them, for example, people could go in and survey that group and answer some of the questions I've had today. So being part of these registries can be very helpful. So, and especially with therapy out there now, and see what the long-term outcomes are going to be and how that may change, even more important for the future. So that's a place you can go to look. So there's some of the manifestations that folks have are unique to hypophosphatasia, and some are just the same old that everybody else treats, and you've got those overlaid on top of each other. So there are things that you can do to try and maintain optimal oral health. Right now with COVID, it's a little more challenging. So some of the things you can do at home to be step up your game a little bit. Doing fluoride rinses if you're prone to caries, tooth decay. There's prescription fluoride toothpaste I didn't mention, but it's 5 times stronger than over the counter. You get a prescription from the dentist if that's your issue. If dental caries is an issue, root caries, crown caries, whatever. Periodontal disease, keep them as clean as you can. Be fastidious about your hygiene, and go to the dentist. Even though it's a different time to do that. We're open. We're seeing patients with great caution as far as social distancing in the office, getting in the office. Everybody comes in with a mask on, which they obviously have to take off, or I wouldn't be able to get in their mouth. But we're all wearing N95 masks and all kinds of precautions. I think dental offices, by and large, have been. We've done a lot of this for years, but the game got stepped up quite a bit here with the whole COVID-19 pandemic. So don't be a stranger, come on in, but stay safe and be careful. So this is what I hope everybody has: good oral health, and it helps improve the quality of your life. And with that, I'm happy to take any questions folks have.